may have questions about how to interact with us on the Inclusion Dialogue. If you have questions or you have topics that you think we should highlight during the conversation, please do feel free to send them to us via email at community@salthouse.africa. Again, community@salthouse, that's SALTHOUSE.Africa. And we definitely will take it up and we will action it, certainly. So to introduce our guest today, Mr. Alhassan Hamza Hussaini is a social development specialist with over 9 years of experience in community organizing, policy advocacy, and program management. He uses advocacy and social behavioral change communication skills to promote gender and social inclusion, empowering women and girls in underserved communities through collaboration with civil society organizations, the government, and private sectors across Nigeria. He has published stories and articles aimed at influencing policymakers to improve the lives of women and children. He joined Plan International Nigeria in the year 2021 as a behavioral change communication and campaign officer for the World Bank-funded Accelerating Nutrition Results in Nigeria project in Niger State, and is currently the Advocacy and Campaign Officer for the European Union Accelerating Basic Education and Livelihood Opportunities for Children and Youth in Northern West Nigeria project. Now, from his background, I'm sure you can tell that we have a lot to learn today from Mr. Hamza. So just to confirm, would you prefer if I call you Mr. Hamza or Mr. Alhassan? Which would you prefer?
Yeah, so please, you can call me Mr. Alhassan. Just Alhassan, preferably. Yes.
Just Alhassan. Okay, great.
Yes.
So Alhassan is joined us in here today, and he's going to be shedding light on a really crucial topic. Now, as for some of you who have been following up with our work at Salt House, you know that we are on a mission to accelerate the adoption of inclusive practices in not just in Nigeria, but in Africa at large. Mr. Alhassan, or Alhassan as he prefers, published a really wonderful article about redesigning, nutritional services for persons with disabilities in Nigeria. And before we go into, I'm not going to waste time talking about it because he has a lot to share with us today. Well, I think I'll put him to tell us a bit more about the article. What led you to publish that article? And maybe you could just share a bit of background about that, the issue you've noticed.
Hello, David.
Yes, can you hear me?
Hello, David.
Yes, hello. I can hear you loud and clear.
Yes, please. Yes, please. Can you take that? Can you take that again, please?
Okay. That's absolutely fine. So what I asked was this: you wrote a wonderful wonderful article about restructuring, redesigning our nutritional services in Nigeria, particularly for persons with disabilities. Now, I just thought we would have like a background. So what led you to that problem? What led you to the problem? Why did you write the article in the first place?
Okay, thank you very much, David. Good morning once again, and good morning to listeners out there. Like you said, I was involved in a nutrition intervention in Niger State that was supported by the World Bank, and I was working as the Behavioural Change Communications and Campaign Officer for Plan International Nigeria, providing technical assistance to the Niger State government through its Ministry of Health and State Primary Healthcare Development Agency, where we're providing nutrition commodities for pregnant women, lactating mothers, their children under the age of 5, and then side by side with some kind of nutrition education in the form of counseling. And after some years into the implementation, we realized that there was a need to ensure the inclusion of people with disability and other vulnerable groups into our programs to ensure that we are able to reach more of them. And so we adapted a strategy in which we actually consulted communities to understand why people with disabilities, for example, not taking up these essential services, recognizing the fact that they are also an important demography in our communities. Then we uh, got information and guidance from the community on how to engage and then identify or target them to be able to reach them with services. So we use what we call the clustered model. And later I'm going to speak more to it in the later part of this session, to be able to reach them. And I find that whole experience very, very interesting. And I feel that it will be useful and helpful to bring it out there, share with other policymakers, other stakeholders, our experience with the hope that, other development organizations, government policy makers will actually find it something relevant, in that experience. And of course, our goal is to promote the inclusion of people with disability and then other vulnerable groups in all development interventions. Thank you.
That's wonderful. And I really like the fact that you made mention of something. You said persons with disabilities are an important demography in not just in Nigeria, but around the world, which is often overlooked. Now, I think the first question I'd like to ask, or the next question I'd like to ask is, from your experience, especially with the project you're currently, the US, I think it's the program with the funded by the United States, is that correct? Or by the United Nations, I presume. Are you there, Mr. Alhassan? Are you there?
Yeah, yes, sorry, I missed that part.
Okay, so there's the program you're currently running, funded by the United Nations, right? Um, from your experience, what are some of the major barriers that you noticed around, the accessibility of nutritional services or information by persons with disabilities? And most importantly, are there particular subgroups, amongst persons with disabilities who actually suffer more than others, who are more disadvantaged than others, if for better word?
Okay. Yeah, thank you for that question. First is to clarify that the program that we did, ended in August this year. And it was actually supported by the World Bank, not United Nations. That said, in terms of barriers that you asked, that actually affects, the uptake of nutritional services by people with disabilities. Yes, there are barriers, and these barriers exist at multiple levels. So you take, for example, at the community level, there are issues around basically communication.
Competition.
People with disability, um, yeah, um, have difficulty in communication. Some maybe language barrier, for example, the language in which those services are being provided, for example, counseling services, or that's what we call the information communications, information IEC, information, education, and communication materials that we use in the form of like posters to create awareness. Sometimes those tools are not designed in a way that is suitable for these purposes. So maybe the posters are written in English, or even if it's written in the local language, for example, in Hausa, some of them maybe did not go to school, are not able to read, those things and be able to comprehend the message. And for example, you talk about the most affected groups. So, for example, if someone is blind, where you have a poster that is not disability friendly, he will be unable to even see what is there, not to talk of reading it, for example. So many things around language and communication actually affects the way that people with disability will benefit from these services and intervention. So, for example, if someone is also deaf, then you're providing counseling, and without the assistance of a sign language expert, for example, this, no way that person will be able to understand or even to hear what you are saying. So you will find that those who are also physically challenged, have maybe what you may call the cripple, they may find it difficult to walk a long distance to go to the health facility to be able to access services. And then there are some socio-economic factors like culture. So stigma may come in, discrimination may come in, and then there's this poverty as well, where people have, do not have transport fare, for example, to be able to visit a facility to take up the commodities or counseling services, probably because of the distance of the location between where the facility is sited, in our communities. And that's why I cited in that article the issue of the Nigerian policy of the primary health care under one roof. Every ward is supposed to have at least one primary health care centers providing primary health care for people within that geographic location, what we call ward in Nigeria. But notwithstanding, you'll find that that facility is located somewhere where someone living in another part of that community will need to travel 30, 40 minutes, sometimes even more than 2 hours to be able to get to the location of that facility. So with that, if someone is physically challenged, traveling this far will be difficult. And then, of course, for all these categories of both the physically challenged, the blind, the deaf, even those who have mental health challenges, they are another subgroup. For example, for all of them, they are children, they are women, and they are mothers to children who need the nutritional services, or they are caregivers to children who need these services. Definitely it will affect the ability of the children to benefit from these services. And then when we take it up to another level, the health facility level itself, the health facility level, there are some challenges as well. Talk about the physical environment. How convenient is it? So sometimes some of this physical space in the health facility are not disability friendly. The design of the infrastructure, the physical infrastructure, say the building, for example, sometimes or most times do not have provision of ramps, walkways, and of course other assistive devices that people with disability will be able to use conveniently to access services. All of these are part of the challenges that the people with disability actually face in accessing the services. So, just to also emphasize the point about stigma and discrimination, So, culturally and socially as well, in some of our communities, there's a kind of stigma that we have towards people with disability, that we do not have the sense of giving them that true sense of belonging, maybe due to certain practices within our community. This may differ from communities to communities, actually, yeah, but oftentimes you see it playing out. For example, if children within an area are playing, say, for example, football, you see that those with disability are hardly involved in that process. So there's a psychosocial impact of it. And that translates to the way and manner, they engage in all activities in the community, including accessing healthcare services, education and all. So I'm just trying to establish the connection between all that social practices and how it actually impacts on their health and well-being. And of course, how does it impact when there is low uptake, when they're not involved in accessing these services? At the end, it leaves them with poor health condition. And so this is the situation.
Wonderful. I thank you so much for that. You mentioned a lot, and while you were speaking, I was writing down a lot of points that you were making. I'm trying to get ideas in terms of like solutions, which I'm sure we are going to talk about in a couple of minutes. But I would like for you to talk about something. You made mention of sign language interpreters when you talked about those with hearing impairment. Now, do you think, in your opinion, that public health workers it should be compulsory? Sign language education should be compulsory for public health workers? And if so, how do you think this can be implemented? Just briefly.
Okay, thank you very much for that. Yes, so sign language experts being part of the, I should say, complementary team that provides healthcare services is quite essential. So it can actually be integrated as part of the modules of training for healthcare workers, for example. So all healthcare workers, for example, will need to undergo intensive training on inclusion for people with disability and, of course, other vulnerable groups. And then where possible, because there are people that go to school to study the sign language itself. So they can also be employed as part of the complementary team in a healthcare facility, for example, to support, people with disability in terms of communication challenges. So I think that we can advocate for some of the reviews of the curriculum, for example, of training of healthcare workers, from the university to colleges of health and nursing colleges, all these, can actually be improved. And then, of course, encourage, the education of sign language experts, understanding their critical need in actually delivering services to our populace.
That's wonderful. Thank you so much for that. I just thought I'd ask that question up because we've noticed that, in our work, we tend to do quite a number of research and engage with, some organizations. They make mention of the same thing. We go to communities, we want to implement a particular project for persons with disabilities. And then there is this gap between, the intervention given and, those who are supposed to benefit from it. And the question we always ask is, why don't we have sign language incorporated into our educational curriculum? Especially for healthcare workers, for teachers, those who sit in crucial positions, in our public services, they should have access to this education. And these are some of the things that we are coming. And I think that's the Office for Persons with Disabilities, in Nigeria, it's something that they are currently pushing for the federal government to disburse funds for disability education. We can make this, this knowledge available and accessible to everyone. So now that you've made mention of that, thank you so much for that. We're going to go to a different question. Now, we know about the Nigeria Disability Act 2018. I think from 2018 when it was passed, I think Nigerians and institutions were given 5 years to implement, the requirements stated in the act. But we're still seeing a lot of gaps. We're still seeing a lot of organizations that are still not aware about the Disability Act. From the work that we've done, we've discovered that. And so, aside from that, now we have the act. People are not informed about the act because people are not well sensitized about it. But aside from that, what other policy gaps do you think exist? I know we've made mention of one, the fact that sign language is inaccessible. Sign language education or disability education is inaccessible. But what other policy and infrastructural gaps do you think exist in regards to the topic, nutritional servicing?
Okay, thank you very much. So, the Nigerian Discrimination Against Persons Prohibition Act 2018, for example, provides, just like you mentioned, that 5 years after its implementation, I believe that's from 2018 to 2023,
Yeah.
all fiscal infrastructures in the country will be refurbished, to suit the needs of persons with disability. And that should include all hospitals across the country as well. For example, when we talk of nutrition services. But today, in the year 2024, we've not seen, so much of that, the refurbishing of existing physical structures of hospitals, meeting the needs of persons with disability. That's that on the one hand. On another hand, we're also seeing the construction of new, buildings, new structures of hospitals, of health facilities in communities that also do not factor in this. So there seems to be a kind of a mismatch between the provisions of the policy and what is being implemented in practice. So this needs to be fully enforced. The provisions of the Act, needs to be fully enforced, in terms of implementation, to ensure that these facilities are being refurbished, and then when new buildings are being approved or when new building proposals are presented, relevant authorities need to check the building plan and ensure that it meets these requirements, So, for example, if that building is to be constructed by the Federal Ministry of Works, for example, you want to see that there should be a synergy between the National Disability Commission, the Ministry of Works, and then the Federal Ministry of Health as well, to look at this and see, okay, does this plan actually serve the needs of the people? And then before it secures the clearance and final approval, to be constructed. If not, I see that we are adding more to the existing body, despite the act being in place. So that's that. On another dimension, there's the National Policy on Food and Nutrition in Nigeria that also exists. If you have the opportunity of looking at that policy document, you will find that, very little, or if anything, is mentioned about people with disability. So, consciously, when policies do not actually, recognize the importance of, attending to the needs of this very important demography in our community, then you are sure that there's going to be a lot of gaps. So for example, based on that policy, there's a food and nutrition committee, for example, across the country. You have those committees from the community level to local government level to state level, that's the subnational level, to the national level. And there's no place for the inclusion of people with disability to sit in those committees, as to represent their interests in decision making, so that when decisions are being made in those committees, you are sure that the interests and the needs of the persons with disability will actually be represented effectively. So for me, to cap this all, there's a lot of alignment that needs to happen, between the provisions between what we have in the Nigeria's Discrimination Against Persons, Prohibition Act 2018, and of course other national policies that like the National Policy on Food and Nutrition, and that kind of inter coordination between the various government departments, ministries and agencies, also to ensure that these provisions are being fully enforced in terms of implementation. Thank you.
That's wonderful. So from what you've said, I think the problem is, first of all, we have the National Disability Act 2018, but it's not a question of how do we encourage other departments or other areas of the, other arms of government to embed what we have in the National Disability Act in their existing policies, if that makes sense, right? That's one.
Yes.
Yep.
Yes.
And then secondly, you made mention of the fact that we also have these policies, but are they being implemented? So we don't really have like anyone who is responsible or who has shown to be or demonstrated that responsibility to ensure that everyone is into this policy and implement based on what the act says. Now, you said a couple of things, and thanks for mentioning the national policy on food and nutrition. It's definitely a policy document that I and my team will definitely know about. Recently, we noticed that even the national constitution does not recognize persons with disabilities. The national constitution does not recognize persons with disabilities. The first time, in Nigeria that we are going to make mention of persons with disabilities, actually in the Disability Act. And I think we're making progress, but there's more work that should be done. Well, I have a question. When you say buildings should be vetted before they are approved, because I try as much as possible not to see this as the big problem, so that we have the faith that we can solve it, right? If everyone putting their hands on deck, but when you say buildings should be vetted before they are approved for accessibility, infrastructures and all of that, who do you think should be responsible for that? Because I'm currently writing a book called Whose Fault? That's the title of the book, right? And in Nigeria, we tend to do the blame game in Nigeria, where you go to this particular ministry and they say, "Oh, it's not our fault. Is this person responsible for it?" And everybody just keeps pushing away responsibility. And I think that has been the issue with implementing the Nigeria Disability Act. That has been a big issue. The last episode of the Inclusion Dialogue, we discussed disability finance. Now, the reason why we mentioned disability finance, because we noticed from our research that the reason why most organizations have not implemented the provisions of the Act, the Nigeria Disability Act, is because they don't want to be responsible for the financial implications. The government says we need to do this, but who is going to bear the financial burden? It's going to come at a cost. Is going to bear that burden. And so that there's this lot of the government saying, "Oh, you have to do it." The private sector saying, "No, I know we have to do, but you have to provide the money," and everyone is pushing the blame. But when you talk about building, infrastructure and talking about healthcare facilities, who do you think should be held responsible for that?
Okay, so thank you for that question. And I think because of this question, we have to be much more specific, in our attempt to address some of these issues. So we know that the workings of government is a bit complex, but notwithstanding there are clear-cut policies and guidelines, regarding processes, in the way, the ideal way that we should do things, So, the Ministry of Health, for example, presents, during budget process, would actually present needs for construction, for example, of hospital, and say that they want to site a hospital in so location. If it is the federal ministry, you can be sure that at the point of approval, it will have to pass through, FEC and all of that. And in FEC, that's the Federal Executive Council, you know that all the ministries are also represented in such meeting, So definitely the plan will be presented, and then there will be opportunity to look at it. But then let's come down to even as a ministry, how do we go about actually, or how should they go about, tackling some of these things? So, and I'm going to touch a little bit about the private sector, and then perhaps it will help to show clearly who is responsible and how should we tackle that. So, as a ministry, there's also a department of either hospital services or clinical services, depending on what level, or maybe having them separately or as one. So usually when you are talking about citing hospitals, they are responsible for that. Even as a private hospital, if you want to secure approval to put in a private hospital, you have to go to the Ministry of Health and get an approval. The ministry, the Department of Clinical Services, as part of their processes, will go for inspection, physical inspection of your facility to see whether it is convenient. This is now in general sense, for people to be able to access care in that location. And that should include, by people, that should include also the people with disabilities. So during that process, these things can form part of the checklist that the ministry will be looking at before you are given approval. And this, I'm talking about, for example, private hospitals, private clinics, and the likes. So for government itself, I believe, I don't work with government, but I believe that if it's the government that is putting up that structure, definitely a plan would also be presented and be reviewed by that department in the ministry. And so one thing that we can do is to get the National Disability Commission, for example, to coordinate and collaborate with the ministry and specifically that department and say, please, this is the need, this is the situation. Just do a small assessment across the country, present facts and figures. This is what we have across the country. So number of facilities presently do not have this provision. And this is where we want to go in the next, for example, 5 years. So please, can we have a situation where all new plans that comes into this department will have to get some clearance from us? Or when you are going for your inspection, can you involve us so that we can, or can we work on a checklist together that you can adapt and be using, before you give this clearance? So I think that I do not actually have the solution per se, but it's something that we can look at and engage and then find, a workable way around it. But then definitely somebody is actually responsible for that. Thank you.
I think that's really great. I think I love the perspective and the fact that you made mention of certain departments within government that should be held responsible, and I took note of them. And we certainly will send them emails. They definitely will hear from us, certainly. So I think the next question I'd like to ask is, I know of and I know this is kind of off, I know of a framework called the AAAQ. I think it has to do with availability, accessibility, and adaptability and quality framework. So it's a framework developed by the United Nations, UNICEF in particular, that it's basically a framework for administering, interventions and all of that. And that's where you ask all of these very important questions. That, so you want to, if you're going to provide a particular public service, for example, there are certain questions you choose. First of all, ask, okay, is it available? That's one. Secondly, is it accessible? By looking at the demographic and who should benefit from it, right? Is it acceptable? And then finally, looking at the quality as well of the service that is being offered. And I think that's something that the truth is, in some ministries that we've actually had conversations with, they are not so familiar with this. And we are thinking of probably organizing a workshop, basically, for key ministries, where we delve deep into this framework, and see what we can do to educate, and not just the ministry, but also down to local government level. For example, I'll give you a really good example. During the food, it's still ongoing, but there was a time when the food crisis was at its peak, and that was just a couple of months ago, right? And the federal government decided to disburse, food palliatives to different states, and that was distributed across. And we noticed from our research that not a lot of persons actually got access to that. As a matter of fact, let me not say not a lot of persons, not a lot of disadvantaged persons, like persons with disability, had access to that. I live in Lagos State currently. At least I've been in Lagos for the last couple of months. And I got to witness, the disbursement of this because of our work within local government. These palliatives were given through, small cells, community, and these small cells, they met in a particular location where they said, oh, everybody find your way down there. But not everyone is mobile. In a couple of days, on Tuesday, we are doing a training in a local government where we are talking about how our roads are not accessible in Nigeria. So there are persons who want to come and get these palliatives, but because they're worried, okay, how do I wheel out? How do I use my clutches, in that noisy body, vehicles are passing and people are unable to come out to get these benefits. And so I think it's really worthwhile if we educate, the government and other key stakeholders on these issues that, before you distribute any form of support or public service, you need to be able to answer some certain questions. What are the people who benefit from it? How accessible is it going to be for them? What channels can we put in place to make sure that it's accessible? That they can, irrespective of the demographic, they can access these things. And I really love the fact that you made mention of some department. That was just to chip in, so I don't forget. Now, we want to talk about innovative solutions. Now, there are quite a number of organizations, including yours, who did fantastic work in terms of, ensuring that certain services, nutritional services, actually meet people who are otherwise, vulnerable or cut off from the system, like women, children, persons with disabilities. Now, can you actually tell me a bit more about the project that you've done? Like maybe the project that was completed in August. How exactly did you ensure a Plan International Nigeria ensure that those people who are not ordinarily have access to certain nutritional services, they actually did?
Okay, thank you very much for that question. Before I answer that, I would like to just also touch on the issue of inclusion for the distribution of items like palliatives and, of course, generally services, and with specific focus to persons with people with disability. And so it's just to say that it's a challenge actually in Nigeria that we've not been able to meet up with some of these conventions, that emerges. So, for example, we have the United Nations Convention that actually provides that 5% of employment, for example, should be reserved for people with disability. That's in every employment slot. So, if you are employing 20 persons, 5% of the 20 persons should be made available for people with disability. We've not seen this happening, for example. So this is part of the problem. So even in distributing other services like palliatives, so we can make it, deliberate to say at least whatever is distributed should be able to reach 5% of the population. And I can tell you that 5% does not also, meet up. It's not enough to actually cover the percentage of the statistics of the persons with disability in every location. So, for example, the global average is 10%. The global average of people with disability in a population is actually 10%. Well, I asked the question, in Nigeria, what is our average? It's actually above 10%. So we have, in Nigeria, we have, based on a WHO data, we have an estimated 35 million people living with disability. I think the last I checked, we had like somewhere around 18% of our population living with disability. I think that we need to double check that. But in any case, in Nigeria, our own estimate is above the global average of 10%. So I'm saying this point because just to show that even if we are able to reach 5%, does not mean that we have actually included all persons with disability. But at least, it's a step forward. And so much actually needs to be done. So currently, the situation where we have the persons with disability not being targeted, not even at 1% or 2%, or the current, the UN convention that says, okay, reach them at least 5% for employment slots and other benefits. We're not able to keep to that. You know that we have a long way to go. So it's just to mention that I come back to your question about our work in Plan International that we did with the support of the World Bank in Niger State, where we implemented the Accelerating Nutritional Results in Nigeria project, the ANRiN project, between 2021, May 2021, up to the end of July 2024. That makes it about 3 years into the implementation of the project. We have actually ended our support, but the state are actually still going on with the component of that intervention. So I would like to just, not go into the details of the project per se, but just, to touch on the aspect that has to do with our work, our effort to reach people with disability with the services. But I think I should also give a few background about the nature of the services and our target beneficiaries. So like I mentioned earlier, our targets were mainly pregnant women, breastfeeding women who are called lactating mothers, and then children from birth, that's from 0 to 5 years old, who are under either caregivers, or maybe their mothers are breastfeeding them directly. Then we'll also have interest in reaching, adolescent mothers as well as part of our target, because Plan International is a women-focused organization. It's an organization that is interested in promoting the rights and the welfare of women and children, and then particularly youth and then adolescent girls. So because of their interest, they form part of our target. And then the services that we're providing to them basically are some nutrition commodities like vitamin A supplementation, albendazole that is given to children biannually, zinc and ORS that is given to children, counseling to the pregnant women and the breastfeeding mothers on what you call nutrition education on exclusive breastfeeding, for example, topics like water sanitation and hygiene, and the rest of them. We also provide iron and folic acid to the pregnant women. We also provide the SP drug, SP sulfodazine primethylene to the pregnant women as well. We also provide some forms of micronutrient supplementation for children, that we call the MMP. So to children. So during the course of this, and then we've reached, at the end of the project, we reach, a very, very high volume of these target beneficiaries with various components of the services. Our report is going to be out, and I hope that you'll be able to pick it and then, look at some of the statistics here by the time we share it, especially that I and you are connected on LinkedIn. So that is that. So in one of the local, we did the work across 12 local government areas in Niger State. And in one of the local government areas, contemporary local governments, we went looking at the situation, and just basically it was for us to see how effectively people with disability actually taking up our services, for example. And then we saw that there's a gap, that the approach, although our community volunteers were involved in home visits where they go to households and then identify these beneficiaries, people who need these services, and provide the services to them. We find that still, even within those communities, within those houses, the people with disability are not, reached adequately with these services, mainly because of some of the issues I pointed, we discussed with you earlier on, that even sometimes when they're in a household, they hardly do come out to show up and say, okay, I need these services. And because often, socially we neglect them, and so they were not adequately represented. And so we had to, call for a meeting with our project stakeholders. We had a local implementing partner, civil society organizations. We were implementing with the state chapter of the Federation of Muslim Women Association of Nigeria from one, and another CSO, civil society organization called the PSK Initiative. So we had to put up a meeting to look at the situation. And then we agreed that we should consult with the community. How best do we reach them? How best do we actually identify persons with disability with these communities, within this community? So we had a couple of such engagements, and then at the end of the day, we identified that what is obtainable currently is that in most communities, and not just in Kwantagora, for example, you'll find that the people with disability are, predominantly domiciled within a cluster. So you find that there's one community that most of them, actually stay there. And why is that happening? Is because they want to benefit from a kind of social support system from one another. For example, if they go to another community where people do not understand their need, they may not get the support, that they need, to be able to survive and to be able to thrive. And so often they stay within those clusters. We actually understand that it is not encouraging because it is a bit isolationist, but then that is what is obtainable given the structures of our communities. And we will hardly be able to just change the way the community from is structured overnight. And so what we did was rather to adapt to this situation and then target such clusters to be able to find more of the persons with disability. So and I'm happy you mentioned about your experience in the food distribution, the palliative distribution. So for example, if you are a planner and you want to reach persons with disability with your palliative or some of these health services, that means you have to make it a provision that so community should be part of the targets. Assuming in one local government you have 10 wards, and then this cluster is in one of the wards, and your palliative will not be able to go around all the wards. And for any reason you want to select, 3 wards. So at least if you want to ensure the inclusion of persons with disability, you may want to pick 2 and then 1 of exactly. So that increases the inclusion, and it enhances their representation and participation. So that's just exactly what we did, to be targeting those clusters so that we can actually reach more of them. And so when you come into a household, it's even possible or likely. It's not that everybody in the house is a person with disability. No, but then within that, households, you may find up to 2, maybe 3, 4, in some cases, even 6 persons living with disability. Or you may find that is a mother, but the mother and the father are disabled, and then they have a child who need this service. And even though the child may not be disabled, he need this service. And because of the condition of his parents, he can actually be excluded from benefiting the services. Because if they have hearing impairment, they may hardly know that they may hardly know what is happening. If they have visual impairment, they may hardly be able to see what is happening. And so, and of course, there are some services that you cannot give directly to the children. So, for example, you want to offer counseling services. You counsel the caregiver in how to actually take care of the young child. And so it is the mother that you want to reach with that service, and then the service will not benefit the child. So you see how these things are interlinked. Exactly. Yeah. So that was what we did. And then, like I told you earlier, we find that to be very, very interesting, to be very, very revealing. And we feel that it is important to share this experience with governments, all stakeholders, civil society organizations, the private sector, particularly policymakers, to look at some of these things and reflect them as we make policy decisions. This may not actually be a perfect fit in terms of solution, but it can be a great starting point, to find better options. And then as we continue to do that, and adapt, review what we are doing, and then we find what is like a workable practice within the community, what we call the latent practice, for example. So we upscale it, we'll continue to expand it, and but in some years to come, you see us having something that actually works. Because the problem is because we're unconscious of the fact that we need to do this. So we don't get to start. But if we have started and we have done some things, and we see that it's working, and then we improve on it, we'll get somewhere, we'll make progress. So it's very important that it is in our conscious mind that when planning and when implementing development programs and interventions, this has to be factored. We need to know that we have an important demography, within our population that requires special attention, that have special needs, and that we need to actually find ways to be able to serve their needs too. And so, my concluding statement will be that, by reaching more people with disability with these services, you have enhanced, their health situation and their well-being. And then you've also, by extension, actually enhance the reach in terms of services to your population, and of course, even the health condition of the entire population, because they are counted as part of your population as well. So they need to be reached with services so that we can reduce the health and of the country. And then if they are, better catered for in terms of health and well-being, their productivity will increase, and so they will add value to the country's national productivity as well. And so adding value to the productivity will also add value to our growth and development, because when they are contributing to GDP, you find some of them creating jobs and employment, being employers of labor. You find some of them being employees themselves, and of course they will pay tax returns to the government, whether they are employees or they are employers, and of course government will have much more resources and our country will grow better. Thank you.
Better. Wonderful. Thank you so very much for that. That was profound. And I certainly look forward to reading your report. I certainly look forward to reading the report itself. I'll be on the lookout. And once it comes up, please, I know you'd have quite a number of persons to send me to, but add it to the list. Please notify me and tell me if it's out you can download it now,
Thank you.
right? So yeah, so I've got a question. I know we have some other questions that because of time, we're just going to speed through it. Some of these questions you've already attended to them. Right? But I'm curious to find out, maybe with the work that you've done or with the work that you will do, what role do you think technology plays in bridging this gap, in ensuring that persons with disability and also other vulnerable groups like the elderly, and so on? What do you think we can do with technology? What would you see technology playing bridging this gap?
Okay, thank you. So, though I'm not a technology expert, but at least through our project, I also work in synergy with innovation team, and so there's an innovation that we actually implemented through that project. We may not have time to talk about it, but for me, the lessons, because it was using, the mobile technology, this SMS, mobile SMS system, to send SMS communications to the communities, to have their feedback on our services, whether they need services, whether they have complaints. And so for me, I think that we can actually leverage on that to reach persons with disability with some information. That's one, depending on the type of disability actually, because some will argue that those who may have visual impairments may not be able to work with that. But notwithstanding, we can actually reach a certain number of them with SMS, because for those who are able to read and write in whatever language, we can communicate with them. Two is it can be an avenue of getting feedback, from them, where they need services. We are aware, and then we can actually deploy, because understanding that need is quite very important to be able to determine what should happen, what we should give to them. So we can deploy the services to them in those areas. So first, it has to start with data capturing. So for example, the persons with disability, there are a good number of them today in this country that have mobile phones and mobile phone numbers. So we can link for example, we call it national identity number. Well, of course, they're already linked to phone numbers. So we can look at our database, look at who are the persons with disability, you understand? From that database, look at, link the phone numbers and be able to establish communication with them. And of course, understand their needs. So it can be a starting point in terms of understanding needs and determining what services they need and how to deploy those services to them. It can be a good start, and we can get a lot of programmers also to program what we can benefit from those data, those information. So, and this also means that we have to do a lot to get them involved in the process of registration of the name itself. And of course, getting them registered in our database so that we can, because this estimate, you see that when you are reviewing statistics, you will see numbers coming from WHO, numbers from UNICEF, for example, or other development partners, numbers from the World Bank. You hardly see numbers from, numbers that are accurate, estimates that are accurate from, for example, the National Bureau of Statistics, or maybe the Disability Commission itself doing a census, or our own, National Population Commission. So it has to start with actually accounting for them, using technology to be able to capture them, have those records, and then establish communications with them. Secondly, we can actually leverage into this technology, the technological world. We can actually deploy home radio programs, low cost home radio programs where we can establish broadcasts, and then for the counseling aspect, get to sensitize them, get to create awareness on their rights, and then establish communication to also understand their needs through those programs. And then once we do that, I believe that there are informations that we can get and then fine tune those ideas into, effective programs that will be able to address some of their needs. So this is the little experience that I have to share in that regard.
That's really great. I really love the fact that you made mention of data capture, because that's one of the major challenges. Recently, we were at the Nigerian Diversity and Inclusion Business Conference, and that was one of the major issues that we talked about. We're able to highlight that yes, we want to provide interventions that would get to persons with disability. Question was, where do we get the accurate data from? And like you rightly said, you read the United Nations report, it says 35 million. You read another report, it says 20 million. Another report saying 40 million. And, it makes it really hard. And also for for example, in Lagos, we don't want to believe, why, hypothetically speaking, you could say that we have equal distributions of persons with disabilities across Nigeria. But that's not always the case. You find out that because of the rise of like polio, particularly in northern Nigeria, you tend to have a particular, persons with mobility impairment often in these regions. And that differs from a different community, like in the South, where kids suffer from, eye defects due to maybe the sort of polluted water that they consume. And then it differs across Nigeria. It differs across Nigeria. And so actually getting accurate data, and I think technology could help us achieve this. And I love the fact, never thought about the fact that you could link the national insurance to this. And I think it's a really fantastic idea. It's a really fantastic idea. Thank you so much for that. Now, I have one more question to ask before we call it a day, right? Now, you're working at Plan International. We are doing the little we can at Salt House, right? What do you think, if you could give just one, I'll give you a magic wand, just one. If there's one thing you could do, if you had magic wand and you could just make one thing happen that could solve this problem or could be a very, very good foundation for future work, what would that thing be to ensure that persons with disabilities have access to nutritional services?
Okay, so for me, everything boils down to the issue of policy enforcement, or effective implementation of policy. And I will explain what I mean by that. Roughly, we have some, maybe let's say, fair policies in place that actually aim to address some of the things we are talking about. But then, like we have identified earlier, the problem has always been the question of implementation. How effective are we implementing that? So for me, I think that I will canvas for more effective enforcement of the provisions of the Nigeria's Discrimination Against Persons Prohibition Act 2018, even in spite of its weaknesses. I think that when fully enforced, it will go a long way in addressing some of this.
Wonderful. So you've used your magic wand, and that is what you've suggested. So I think it's a really fantastic one, because again, it's one thing to make wonderful policies, but if those policies are not being enforced, the desired results will definitely be far, far from rich. Thank you so very much for this, for taking time out to join us on Inclusion Dialogue. And I have a strong feeling that we are going to bring you back at some point. I have a very strong feeling we are going to bring you back at some point, because again, you cannot, it's not a one-off conversation. It's one that you have to keep having, and you have to keep sharing ideas, and which is what we're trying to do with the Inclusion Dialogue. We get experts on the field to share their ideas from their experience, so that we'll be able to create this web knowledge exchange, because nobody can do it alone. As long as inclusion is concerned, the cake is too big for everyone to we all have to work together to eat the lion. So that's about it. I think that brings us to the end. I don't know if you have anything else you'd like to share before we bring the meeting to a close.
Okay, thank you so much, David. It has been a great time, speaking with you on this podcast. I think for me, first is to appreciate you so much for, having interest in our work, especially as it has to do with inclusion. And I'm very quite happy to have the opportunity to share, my thoughts and experience, on this session. And like you said, I hope that we will have more opportunity to collaborate in the coming days in our collective efforts, to promote inclusion. At Plan International, inclusion is part of the core things that we do, gender and social inclusion, basically. So I believe that with time, you get to have more of my colleagues also on board, to speak with you, to share the good work that Plan International is doing across Nigeria as it relates to inclusion. Anytime there's an opportunity where you feel that you want to speak with us, please feel free to do so. Very, very much available. Thank you.
Wonderful. Thank you so very much for that warm invitation. And yes, we're definitely going to be right here with you. And also, maybe in the next couple of weeks or months, we could also collaborate with Plan International on some workshop, because we have quite a number in the pipeline that would be beneficial to, to different parts of government. And it would be great to have really worthy partners on this project as well. So thank you so very much. And yeah, everyone was joined in case you have any questions for Mr. Alhassan or Mr. Hamza, or Alhassan as it refers to be referred to, please do send them to us at salthouseafrica@gmail.com or community@salthouse.africa. And we definitely will forward to Mr. Alhassan, and you will get a response. Thank you very much, Mr. Alhassan, for making our time to be here with us today. And we certainly look forward to an interesting future for each and every one. Bye for now.